Hi, everyone, and welcome back to the Tools for Perseverance. This is Dr. Jessica Wright, and today I wanted to go over the third part of our trauma skills series and talk about trauma experiences in frontline workers for our healthcare workers, for those of us that are patient-facing. So let's get started. So first, I'll start off by talking about secondary trauma in clinicians. So secondary trauma is also called vicarious trauma. It's also called compassion fatigue. And most of our frontline workers will be familiar with this. They'll be familiar with this idea, this concept, because it's something that we talk a lot about, especially in context of resilience, in context of burnout, in context of the nature of the work that you do as clinicians, as frontline caregivers. The definition of it is a psychological byproduct of prolonged exposure to other people's trauma, resulting in negative impacts on physical and mental health. So it's an important idea to recognize it's a byproduct of the work that's being done. It's a byproduct of prolonged exposure to other people's trauma, resulting in negative impacts on physical and mental health. Nowhere in this definition does it refer to an individual as being weak or not strong enough or not able to hack it or take care of it. I want to make sure that we dispel any myths around this secondary trauma being in any way I want to dispel the myth that it's in any way a moral failing on the clinician. In fact, it's more often associated with individuals that have compassion. That's why one of the words for this is compassion fatigue, right? For people that are, excellent caregivers, this is a real threat, and it's a real thing that you are probably very familiar with. This psychological byproduct of prolonged exposure to other people's trauma, resulting in negative impacts on physical and mental health. So I went and found one of the first studies that's been published on the idea of this secondary trauma in clinicians for COVID, and it was published in Brain, Behavior, and Immunity. And the title of the paper, if you wanted to look it up, is Vicarious Traumatization of the General Public, Members and Non-Members of Medical Teams Aiding COVID-19. So what I liked about this article was it described how secondary trauma is experienced by people who care for individuals with this disease, and then what interesting and novel things that we found. So it was specifically looking at people caring for individuals with COVID. And interestingly, the most novel or the most interesting aspect of this article was it found the biggest impact, the biggest amount of secondary trauma was being experienced by non-ICU nurses, so non-critical care nurses. So nurses who do not normally work in the critical care or emergency room was also included in their environment. Essentially what this means is that the biggest impact was seen by nurses who are not, they're accustomed to working and caring for patients, but not in the most critically ill area of the hospital. And so the description of this in the article talked about how possibly because individuals in other areas of the hospital are likely to recover versus individuals that are in critical care, they may recover, they may not. And the amount of trauma experienced in an emergency room and in a critical care unit is significantly higher than in other units. They also postulated, they had a really great phrasing, so I'm going to try to find the exact phrasing for it, but essentially they said possibly this is happening because people who are ICU nurses or critical care nurses or physicians or respiratory therapists or all the wonderful people who work in that area may not have had as large of an impact because, and this is my quote for them from the article, is that psychological endurance of frontline nurses is stronger in critical care. And this notion may due to the fact that these nurses are voluntarily selected and provided with sufficient psychological preparation. Essentially saying that they are, if you are a nurse working in critical care, you know what the drill is. You know what this is your day-to-day life. This is your bread and butter. And you're, if not accustomed to it, the idea from this article was that you have built the psychological capacity to deal with the type of trauma that is part of your daily work. So I'd love to hear your thoughts on that. That's a pretty interesting finding. It's a pretty interesting opinion from this article. And I also wanted to point out that the biggest problem with secondary trauma in clinicians is that during COVID-19 is that it's being combined with primary trauma. Everything we talked about in the first two sessions about trauma being this emotional response to an event that creates fear and unpredictability and leads us to feel like our life is under threat. That definition of trauma that we gave before is the definition of primary trauma, as someone who's enduring an event. So these frontline workers, the biggest impact is happening with all frontline workers that are working with COVID cases as secondary and primary trauma together. Because they are dealing with patients when they go to work, and then they are dealing with the trauma the rest of us experience when we go home. Going to the grocery store, worrying about loved ones getting sick themselves, their loved ones getting sick. So the COVID-19 situation that we are in is causing our frontline workers to have a combined secondary and primary trauma. And we're seeing this with different groups of individuals, and there's a lot of response from our colleagues in the field of psychology as to what to do with this. You know that mental health is an enormous issue. Unfortunately, we have lost at least one physician to a mental health problem in New York City after dealing with all of this trauma. So there's great attention being paid to making sure that our frontline workers have the mental health support to endure past this trauma and to heal from it. So I will share with you from psychology literature, Dr. Deborah Glassoffer created this in an article she published on Psychology Today about mental health first aid for first responders. I'll go through what her thoughts were as a general advice, and then we'll get really concrete on some specific resources available to you. So first, her first piece of advice was breathing, and she starts off in this article, she started off by going, I know, it's hokey and you're busy. So she admits that we are all told to breathe a lot. I know I personally have, when the breathe notification comes on my iPhone, I get annoyed by it more often than not and turn it off. But deep breathing is, number one, always accessible to us. Number two, does not require us to touch our face. And it is something that is shown to lower our blood pressure, reduce the effects of fear, stress, anxiety, and other parts of trauma. So the key component with breathing, you don't have to do a yoga class or, become very proficient at mindfulness, although, I will always recommend that. Breathing is really about counting your inhale, and exhaling for 1 second longer, and then rinse and repeat. Count the inhale, exhale for 1 second longer, and do that collectively for 30 seconds, a minute, 5 minutes. How many seconds can you allocate for this? And take some time to do the breaths. They have a physiological, a psychological impact that's immediate. So that's number one, breathe. Number two, lean on reliable support resources. It is not a time to become the soldier or the cowboy riding along through the desert on a horse by yourself. This is a time for relying on resources. So one of the most effective ways of doing this is finding a, quote, work buddy, someone that you work with that you can step out, grab a cup of coffee, sit and say, oh my God, this is insane. I can't believe I had to deal with this. Or just to sit in silence, or to go somewhere private and then break down in front of them. Having someone that you work with that knows this in and out that you can rely on is going to be really valuable. In a second, you will talk about really specific resources that we have available for our frontline staff at Methodist, but you can also think to go to people who are older than you, who have been through this. So any of our colleagues who were working during the AIDS epidemic when it first started, the level of fear around the disease because it wasn't well understood, that can be really valuable. Anyone that has worked internationally with other diseases such as Ebola that are highly infectious, that have these types of, learn from the individuals that have done this before. Okay, Dr. Glassoffer's third bit of mental health first aid was accept that anxiety is going to be an unwelcome house guest in your life for a little bit longer, right, while all of this is happening. So you need to not try to fight the internal alarm that anxiety is going to be producing in you. And instead, like we had talked about in other sessions, look for those doorbells, those things, those physical and mental signs that you are experiencing anxiety, and then immediately focus on something in the present. Right? Anxiety is going to be something that is part of your world for a little while, and becoming really familiar with what your signs of that you are having an anxiety experience, becoming really familiar with those, and then finding a way to focus on the present. The idea is that anxiety is always future oriented. It's about worrying about your future security. Instead, focusing on the present, finding a way, leaving the unit to look out of a window. Next time you're able to, like, walking down the halls, trying to go outside and feel the wind on your face. Any of these things to focus on the present are going to be really helpful. But having a plan and accepting that anxiety is going to be an unwelcome house guest in your brain for a little while is going to be really, really valuable. Take stock and evaluate your contribution to helping. So I'm going to read this directly from what she had written in that article. She says, the decisions you may be asked to make or carry out in the weeks ahead may not come with ease or without impact on your psychological well-being. Secondary trauma can manifest in ways including sleep disruptions such as nightmares or exaggerated startle response. If you or someone you're working with is experiencing trauma symptoms, remember that there are other people to help you and the public, and that specifically, remember it is not selfish to take a break from caring for patients, and that the quality of your contribution may be improved by a modest reduction in the quantity of your contribution, right? If you are at a breaking point, stopping and taking a break is not selfish. It is the best way to help the patient, is her point in this article. And then finally, recharge. This really is focused on preparing your time off for max decompression. So whenever it's time to decompress, use it. Fill your days off with hours of sleep, meals that you're looking forward to. Fill your days off with FaceTime, or virtual FaceTime with people that you care about, watching movies or shows that you love, being in pajamas all day long, not leaving the couch. You really want to lean in and recharge to the max of your ability, right? Those were Deborah Glassoffer's suggestions. And then finally, remember at Methodist we have our Taking Care of You email that goes out every day, and I wanted to make sure you all saw they have an employee assistance plan Our EAP allows us to have 10 visits to a psychiatrist without a fee. Right now, I think specifically for clinicians, there is a great resource called a peer support request, in which you get connected to a peer, so someone that is a clinical psychologist or licensed social worker that is there to support you, who is also a clinician. And then on the My Methodist app, our virtual behavior app is $0 copay for Houston Methodist employees, which is a really wonderful thing that they are doing for us at our hospital. There's a daily Compass WebEx, which is basically an online support group at 11:30 a.m. every day. Care Connect TV when you're in the hospital. And you can request a prayer from our chaplaincy services. So here's what I'm going to ask you, and what I want to know from the chat box is, what can you do to support a colleague in getting the help that they need when you notice that they are having symptoms of trauma? And perhaps it's the combination of secondary and primary trauma that is being experienced right now by clinicians. What can you do to support a colleague in getting help? How can you make that easier for them? That's what I want to hear you talk about in the chat box. I can't wait to hear what you have to say. Thanks.